Have I already shared my screen?
I still see you.
Okay. Let's see. Share content. Try this.
There you go.
Let's see if this is if this is my lecture, this is yours. No, I think this is your lecture again. Um, so let's not do that. Let's share screen. Okay. How about now?
There you go.
Yeah.
That looks much prettier.
Okay, great. And we'll do a slideshow. Um, oh, there's a hand raised.
We're good.
Okay.
I'd say we're good.
Okay, someone's got a question though here. Let's make sure that okay.
Looks like we're good.
All right, let's do it. So this is who I am. I'm Eric Shurtleff, one of the trauma surgeons. I am the EMS liaison for the trauma service. I was at one time an EMT, and I love that job. And so I've carried that with me into trauma, and that is really my main research interest and um, administrative interest is doing everything we can to be a trauma team across the entire state with y'all. So again, appreciate you coming and taking the time to listen. So here we go. Um, let's see. Nope, nope. Hang on. Okay, these are our learning objectives, which I've already kind of gone through. So chest trauma. Most of this will be a review, but we find that a periodic review helps promote kind of long-term memory of procedures and those types of things. So we'll go through it. Sort of your protocols are integrated into the lecture here. But for the EMT basic oxygen, I would say in all cases, I would put patients on oxygen, at least a couple of liters. You want them to have reserve if they start decompensating. Um, if they need assistance, absolutely. If you're in a situation where the patient is really critically injured, I would say ALS is in all cases, if possible. Um, Impaled objects, that's an interesting question here. It is something we actually have a case presentation here that deals with exactly that. But in general, removing them can only make things worse. So you definitely want to put bulky dressings around to stabilize whatever the object is and then to tape those down in place. But the goal is if you have a penetrating object into a chest, you do not want to move it. Um, and then you monitor for air leak around around the object. So if there's bubbling or blood or something like that, the idea would be is to seal that as best as you can, because that type of thing can certainly lead to a progression into a tension pneumothorax. Um, or flail segment, respiratory distress. I would say assisted ventilations is probably going to be necessary in those patients if it is a true flail segment, which is three or more ribs that are fractured in two different places and they're next to each other, contiguous. The splint is definitely not something that will help this patient, unfortunately. It's still in the protocol, but the trauma service would recommend against that. I think really what you're trying to do is get that patient here, keep them oxygenated as best as you can. Those are the broad strokes there. And a 12 lead EKG on these folks would certainly be of use. Because oftentimes you'll have cardiac injury that goes along with a serious chest injury. For the advanced EMT, IV access particularly is important, and it is probably the number one life-saving intervention you can do pre-hospital, but it can't prolong scene time. I guess that's the trick. I'm sure y'all have heard this a time or two before, but what's important here is to get the patient moving as rapidly to the hospital as possible, but then also if you getting access. Typically, somebody has a serious enough chest injury that you're assisting ventilation, you're concerned about flail, and you're concerned about decompressing them. They will also need volume. So a liter of fluid en route is always a good idea. And then, of course, get a hold of your online medical consult with the with the ED service. That way they can notify us too. And if you have a paramedic, again, ALS, if available, get them involved early. And then for presumed tension pneumo, and so we'll talk about the nuances of really making that decision and that diagnosis in the field, which is always much more difficult for you all. I got to say, I'm always impressed with the field diagnoses that you all can get to without any imaging. It was always the thing when I was an EMT, like it would drive me crazy not really knowing what's in there, like what's in the what's going on in there, where's the injury, what does it look like? And so I guess I would welcome you when you have somebody and you bring them in, if you have the time, we can bring you back to check out the CT scan. I think that's very educational. And in controlled circumstances, it can be really useful training opportunity and education opportunity. So if you see me in the trauma bay, please ask hey, can I come back and see the imaging? And if it's a reasonable time and the situation's okay, I'd love to take you back so you can see the scan. But at any rate, for presumed tension pneumo, performing a chest decompression is indicated. And typically we are using the Maine EMS approved devices, of which I've got an example here later in the slideshow, but I think you're all kind of carrying these at this time. It should be preferentially performed in the fourth and fifth intercostal space in the anterior axillary line. And so we'll talk about exactly where those landmarks are and exactly how to find that space. The the thing that changed here in the protocol is that it used to be the second intercostal space in the mid-clavicular line. And that is still a bailout if you fail with 2 attempts, but we have found, over case series and in meta-analyses that the anterior axillary line is actually you'll have a higher rate of decompression at that location. So we'll talk about how to find that here in a little bit. But let's first talk about physiology of chest wall injury. And basically, the first thing we'll talk about is a simple pneumothorax. So what you notice from this slide here is, can you all see my clicker? Can they see it, Eric?
I can, yes.
Okay. So what you'll notice from this is that the lung is down here versus the left side. The right lung is down. And there is air in the space between the lung and the chest wall. So there's been a laceration to the visceral pleura, which is the membrane that covers the lung. And the parietal pleura is this membrane out here, which is the lining of the chest cavity. Other thing you'll notice of the mediastinum, which is the heart, the great vessels here, the trachea here in the the superior mediastinum, that's all midline still. That can be a helpful diagnostic tool, but typically people with a simple pneumothorax are not in as profound respiratory distress as somebody with a tension would be. We drop lungs all the time in the operating room to fix ribs, and so a lot of people can actually tolerate a single lung pneumothorax, especially younger, healthier folks. That may not be the case with some of our older patients, but you may not see, you certainly will see a less pronounced respiratory distress or failure with a simple pneumothorax. And in general, you won't see the obstructive cardiogenic shock pattern that you'll see with tension pneumo, which we'll talk about here in a little bit. But typically, they may be a little tachycardic, but they should be perfusing, provided this is an isolated injury. They don't have something else going on. And how we look at the interface here, and this is actually, I kind of like this image. This is from the advanced trauma life support slides and the course that we give all the starting interns. But you can see the lung is here, and then the parietal pleura is here. So visceral pleura is on the lung. Parietal pleura is lines the chest cavity. The ribs right behind there. Then there's fat and skin, and then this muscle here, where we're going to teach you to or go over where to put the decompression catheter, goes to the serratus anterior, which is what this muscle is here. In between the ribs are the intercostal muscles. Beneath the rib is the neurovascular bundle, which is why you want to go over the rib, because if you lacerate one of these things, they can bleed and cause a problem. That's an intercostal artery. So that's just the general anatomy and then a simple pneumothorax. So this is the pathophysiology of that injury. You'd get positive pressure air entering the pleural space, which is generally negative pressure. So there is negative pressure between the visceral pleura and the parietal pleura. And so introducing positive pressure from the injured lung into that space is what pushes the lung away from the chest wall. That contact and that negative pressure allows the lung to slide as you take deep breaths in and out. Most are caused by blunt and penetrating chest trauma. The most common cause is a lung laceration, and the most common cause in blunt trauma is going to be rib fractures. We see an awful lot more of those than penetrating, but we do see a fair amount of penetrating trauma to the chest as well, especially in the last couple of years. It seems that incidence is rising. Um, but the basic mechanism is something cuts a hole on that visceral pleura, that membrane that covers the lung, and that allows air from what's inside the lung, which is positive pressure, to push into that space, and that overwhelm, and then that collapses the lung. You'll in the field diagnosing this is can be tricky, but they'll have diminished breath sounds on the affected side, so it'll be harder to hear. In a rig that's hard to hear, but hopefully, as you're assessing, you're quiet enough, you may be able to notice that as you're getting them on the gurney or on a backboard or something. Hyperresonance to percussion is another thing, although percussing the chest also is sort of difficult to do in the field. One difference between one kind of physical exam difference between this and tension is that the trachea should still be midline in a simple tension. And the patient may be a little hypoxic, but not always. Like I was talking about before, younger, healthier people can tolerate a single lung being down all the way and not be hypoxic. They'll be uncomfortable though. Like having a fully collapsed lung is not a comfortable situation for patients. Most of the time, as long as there's no other injury or no other cause for hypotension, they should be normotensive. And that's another big differentiation between tension pneumothorax and simple pneumothorax is to truly have tension physiology, you must have hypotension. Because in that case, there is so much positive pressure in the chest that the heart cannot pump effectively. And we'll talk about that in more detail here in a couple of slides. So without further ado, here's tension pneumothorax. So same thing again, you'll see the lung is collapsed. But what you notice here is that everything is starting to shift away from the injured side. So you're going to have mediastinal shift, the heart, the great vessels, the trachea, they're all pushing to the left. And that is not a stable situation. That patient will die if this is not rapidly decompressed, which is why we do decompressions in the field. The physiology is a little bit more complex, and let's talk about it here. The cause is a one-way positive pressure air influx into the chest cavity. So it's usually a larger laceration in the lung, or an open chest wound can do this. And as that positive pressure accumulates in the pleural space, both volume and pressure increase with each breath. So if you think about it, the injury has to be, somewhere bigger than 2-3 inches on the lung can do this. We'll talk about diameter of inflow in a minute here on open chest wounds, but if you think about it that way, someone with really significant chest trauma that's hypotensive and is hyperresonant, you see mediastinal shift, those are the things that you're looking for. But you will, that may be harder to tell, especially if they have a lot of other injuries in the neck, the head, or extremities. The mediastinum, everything shifts away from the affected side.
This compromises preload. So what I mean by that is blood returning from the abdomen and the lower extremities, and then blood also coming back down from the heart through the superior and I'm sorry, from the head through the inferior vena cava and superior vena cava. That pressure is low. That's about the lowest pressure in the body. Central venous pressure, if you're familiar with that, is probably on the order between 8 and 12 millimeters of mercury. If you have a patient that's also hemorrhaging, that can be even lower. And in fact, I would say most traumatically injured patients, even if they are not significantly hemorrhaging, will have an inflammatory response that will shift volume out of the intravascular space. So the issue there is that you have the inability to get blood into a pressurized space. The blood's trying to get back there as the heart is pumping, but it cannot get to the right side of the heart because it doesn't take a lot of pressure to overwhelm that system, right? Because if we're only thinking about 12 millimeters of pressure, think about normal blood pressure is 120, right? But the pressure coming back on that right side, central venous pressure, is much lower, so it's not hard to overwhelm that very delicate balance. This what you'll see here is an obstructive shock pattern with a narrowing pulse pressure, progressive tachycardia, and hypotension. And once the heart can't pump it, it will pump faster, but you'll have less and less blood entering the left side to move out to the systemic circulation. And so eventually you'll have PEA arrest if this isn't corrected. So in the field, again, breath sounds will be decreased to absent. They'll be hyperresonant to percussion. You should see tracheal deviation. Neck vein distension is basically that you may or may not see this. It also depends on body habitus, but if you see that, what that is it's the blood trying to return down the jugulars from the head circulation and not being able to make it in the superior vena cava. And so it just backs up. And that same thing's happening internally in the abdomen and the lower extremities. And the chest will be expanded and immobile. That's generally true. Somebody who has a true tension, they'll be pretty hyper expanded. They won't be able to move it in or out much, and then they'll also be in shock. So these are the folks that benefit from needle decompression in the field. So it's a little brief discussion about open pneumothorax penetrating chest wounds. What happens is the interthoracic pressure, that space between the lung and the chest, reaches equilibrium with atmospheric pressure. And if the injury is 2/3 or greater of the diameter of the trachea, it's going to favor entry into the chest from the outside. And that can eventually evolve into a tension pneumothorax if there isn't a way to egress to get the air out. And so in the field, there'll be either decreased or coarse, noisy movement of air through the chest wall injury when you auscultate, and they will be dyspneic to kypnic. They will be in respiratory distress, and most likely hypoxic unless they're young and healthy. And so the treatment for this is a three-way dressing, which allows air to escape but not to enter the wound. So when they breathe in, that bottom part of the trapdoor shuts down against the skin, so they don't bring more out. But when they breathe out, air can escape, and so this can help bring that lung back up. A massive hemothorax is defined as 1,500 milliliters of blood in the chest. You'll notice that the trachea is midline here. The mediastinum is midline. There's an awful lot of blood that's collapsing the lung. But it's important that we are able to differentiate this from tension because this does not benefit from decompression in the field. In general, someone that has this much blood in the chest will need an operation, but decompression can actually make things worse. most commonly caused by penetrating injuries to the greater vessels. So that's talking about the aorta, the takeoffs of the carotid, the subclavians in the chest, or the pulmonary vessels can do this. And it can also be caused by blunt trauma. If you have multiple intercostal arteries bleeding in that space, or you have blood trauma can also cause subclavian and carotid injury. Um, you'll have absent breath sounds in the presence of shock. In general, someone loses 1,500 milliliters into their chest, they will be shocky, but they will be dull to percussion. Neck veins will be flat because they're bleeding, not because of any other issue. And the trachea will be midline. So again, this patient really benefits from rapid transport and maybe a liter of fluid en route, but there's nothing else you can really do for this patient other than to get them to a trauma center as fast as possible. We say like diesel bolus is really what's indicated in patients with hemorrhagic shock, and that this patient falls into that category. Um, so here's a and hopefully, Eric, we can make these slides available to them, yeah, so they can review.
Absolutely. We also make the recording available to them.
Great, perfect. So this is a nice table that differentiates massive hemothorax from pneumothorax. So you decompress one and not the other. Again, a lot of these findings are subtle in the field and difficult to tell what's really going on, but you have to use your best judgment. Tension, you'll have decreased absent breath sounds, you have hyperresonant percussion, the airway will deviate away from the injured side, neck veins will be distended because the blood can't re-enter the chest, and the chest movement will be expanded and immobile. Conversely, a massive hemothorax, they will also have decreased breath sounds, but they'll be dull to percussion, trachea will remain midline, the neck veins will be collapsed because they're hypovolemic, and the chest will be mobile. And probably the respiratory distress will be different. They'll be breathing probably quickly. They'll be tachypnic because they're in shock, but you'll notice that there doesn't seem to be like asymmetry in the chest wall motion. If that helps explain that a little bit. So we kind of shift out of all of that stuff into application. So we're going to talk a bit about the procedure and the devices used for needle decompression. So this is the axilla, and it's on a young, healthy male that this is pictured. It's a male and female, a little bit different in how we approach it, but the principles are the same. So the anterior border of the axilla is the lateral edge of the pec major. So if you can find that, okay, that's the anterior border. The posterior is the lat. So it's the latissimus dorsi posteriorly. If you can find that, now you're thinking, okay, in between those two lines is where I'm looking to go. The fifth intercostal space is the lower limit of where you would go in the triangle of safety. And that's defined in males as in line with the nipple, and in females as in line with the inframammary fold. You want to be above there. You want to be in the fourth intercostal space in general because especially with patients that have cardiomegaly, older folks, you want to be somewhere you want to be in the rib space above this one. And in general, the ribs go obliquely and diagonally through this space. So where you want to actually place the catheter is in the just anterior to the mid axillary line. So I know that's a little bit different from the protocol, but this is the safe zone to place this. So if you're too far anterior and too low, we've got a couple of cases that will show what can happen, especially on the left side, which is what's pictured here. So in general, that's a safe place to access, is just anterior to the mid axillary line in the axilla. You'll notice too, this patient's position with the arm behind the head. That's really important. You can test on yourself, and I've done this little exercise at a couple agencies I've been to, where if you put your hand right under your armpit with your arm down and kind of hold onto the soft tissue, then you lift your hand up, you lift your arm up over your head, you'll notice that where your hand was placed before shifts significantly upward, significantly superiorly. And that can be the difference between putting something way too low and putting it in the right spot. So in general, there's not really a contraindication to placing the patient's arm upward. Even if there's an injury to the arm, it can go upward. Even if there is a clavicle injury or a humerus injury, you can mobilize the arm at least 90 degrees off the body, the upper arm, the brachium. And that can be the difference between 2 or 3 rib spaces. Um, these are the recommended lengths. I think most everybody has something just like this, and I think what generally what people have is the main approved devices. Excuse me. This is for newborns. God forbid you have to do this. They're only an inch long, 24 gauge needle. So that's something that's not a typical. That's something that you'll be carrying with you, just like an angiocath in general. Same thing for infants. 5 to 9, we use the smaller, shorter ones, the 3.2, and then 10 to adult statute gets the 4.5, 18 gauge. But most of the people we're talking about are adults that are going to be involved with this. And in general, we're using the 8.2 centimeter, 3.25 catheter. That's what we see the most of. But I think, I defer to pediatric surgery to talk about smaller humans. Here's some of the pearls out of the protocol. So the fourth or fifth intercostal space on the anterior axillary line, I would say anywhere between the anterior axillary line and the mid-axillary line is a safe place to put a catheter. If you're on the anterior axillary line, you still run the risk of if you're not high enough, of hitting the heart on the left side, which is why I would step off about a finger breadth off of the pectoralis major at that anterior border if you're going to place it on the more anterior aspect. In general, if you're angling your needle upward, and we'll talk about this again as we get through the actual procedure, if you're angling your needle upward at a 45-degree angle over the rib and you stop when you hit air, you should be okay. And so anywhere between the anterior mid-axillary line and the fourth intercostal space. You can hit the fifth, that's okay, but ideally the fourth. The goal is to decompress air, which you can accomplish in either of those spaces. The position fourth or fifth really doesn't, they have the same effect. But the reason that we moved to the axillary approach is that there's basically half the failure rate of what we had previously with midclavicular approach. That's why we use it. Again, though, if you fail twice from the axilla, midclavicular is still an option. I think there's probably some medics that have been doing it a little bit longer that have done a lot more of and feel more comfortable with that area. And so that approach, and that is not a wrong approach. But those tend to fail more because you have to go through more soft tissue. So you're going through the pectoralis and you're going through the skin and subcutaneous tissue. So again, larger average depth to the thoracic cavity is what I'm talking about, but it makes sense. Like the pectoralis is a lot thicker than the serratus, which is what you're going through from the axilla. All needle decompressions are at risk of kinking or clotting or not reaching the thoracic cavity. Patients undergoing needle compression should always be monitored for change in symptoms. And I feel like most of the situations where I see somebody needle decompressed in the field, that people will have a really good handle on what's been going on there. So like, hey, yeah, it was working great. Then they started to get more hypoxic. It didn't really seem like it was working again. So we either replaced or we troubleshot and things improved again. So I think once they're in, they're being managed really well across the state. But in general, if you have a concern that your decompression is failing, it should be repeated. And again, if the original procedure site was in the axillary, go to the midclavicular and vice versa. So these are the steps. Again, assess their chest respiratory status and do they have tension pneumothorax? Are they evolving? Are they progressing to that? Like, are you seeing blood pressure dropping, heart rate rising? They have a hyperresonant chest. They're clearly in respiratory distress. Those are the patients that benefit from this. The other ones that are maintaining, they're doing okay on supplemental oxygen, but they're not worsening. They're normotensive. Those patients do not need a needle. again, I would say for all blunt chest injury, get them on oxygen from the get-go. It never hurts to have reserve in case things go south. Surgically prepare the site for insertion. Again, in kids, sorry, again, I didn't mention this before, but in kids, it's a sacred intercostal space. It's still there for children. For adults, fourth or fifth intercostal, anterior to the mid-axillary line is what's indicated. Anesthesia is great if you have time. If they're dying, get it in there. Prep the skin and get in. Insert the over the needle catheter about 3 inches. So you don't need to put the needle in 3 inches. I find that if you aspirate the syringe while you're advancing, that will tell you when you're in the chest, because if you have a little bit of 3 cc's of saline in a syringe as you're advancing the catheter, once you see air bubbles, you're in. Then you can advance the catheter, but not the needle. When you advance both the catheter and the needle, it's almost impossible, unless the one's completely collapsed, not to injure the lung or some other structure. So that's a really important point about this. As soon as you're starting to get air, see if the catheter will advance in, and then push the catheter in all the way and secure it, and then remove the needle. I think, in high stress situations and with difficult, patients that are crashing, it's very easy to forget that important step. But a needle into the lung itself won't be effective in treating the tension pneumo. So as you're going into the rib, 45-degree angle to the rib. So that's from vertical, basically. So if you're approaching the rib like this, I don't know if y'all can see me, but you're going to be pushing the needle in at 45 degrees to the superior aspect of that rib, 45 degrees upward. When you direct the needle over the rib into your costal space, and you aspirate while you advance. A 5 centimeter catheter reaches the pleural space in 50%, 8 centimeters reaches 90%. But again, the key is once you see air bubbles, you should be into the air. At that point, see if you can advance the catheter. If not, go a little bit farther with the needle and then get the catheter in. But advancing both all the way to the hub from the outset will be less likely to result in effective decompression and will be more likely to injure the lung or some other underlying organ in the chest. When you're through the pleura, remove the syringe, list for escape of air as the needle enters the chest, indicate relief of the tension, advance the catheter. So that's what I'm talking about there. But like I said, as you're aspirating, if you can see air entering, then you're sort of in that spot. At that point, take the syringe off. If the air rushes out, you're in. Advance the catheter and you're done. Then stabilize it, and then again, recheck it periodically. Watch your patient close, like you all do such a good job of. Once the catheter's in place, leave it open. Do not cap it, pigtail it, or three-way stopcock the hub. Leave failed attempts in place. That's also important because it helps us deal with them if there's an injury to something. And then if there's blood return, that is the only instance where you would cap it. Okay, so if you have blood flowing out of there, pulsatile or not, you should cap the tube. And all of these things, even once you get it in, especially if things aren't working right, doesn't look okay, something's off, call us. And we can help guide you through troubleshooting and getting the patient here. And also it helps us mobilize either the OR, blood bank, all those things with a critically injured patient. The sooner we know, the more effective we are at handling them once they get here. So here's the first case that we're going to talk about, kind of some case reviews here. And there is an agency here that's listed, but this has happened. I think all of these, it's happened all over the place. In fact, it's not a something that it's something that we just kind of need to talk about as a team in the state of Maine. So agencies are kind of irrelevant here. But there's a patient with unknown medical history, unhelmeted motorcyclist struck another vehicle. Bystanders stated the patient flipped in the air before hitting the ground. So someone took a real shot. EMS reported an open posterior head wound, right arm fracture, large laceration, needle decompression to the right chest. Patient was taken by EMS and intubated and then brought to Maine Medical Center. A severely injured patient. The complication here was that there was a decompression needle to the right lateral chest that ended up in the right hepatic lobe. And so you can see that here. That's the catheter here, and then you can see that it ended up here in the liver. The patient did have contusions here, certainly seemed like they had breath sounds that were diminished or decreased, and there was concern for shock. So it wasn't an indication issue. I think it was more an issue with placement, obviously, but I think that comes from we introduce the technique once, and then it's quite a while before people get a chance to use it or see it used or learn from it being used. So if anything, it's just a systems issue that we're working on fixing. So, but this is how systems issues manifest. They did the right thing. The catheter was left in. The catheter was left in. We evaluated the patient. We removed the catheter, and the patient did fine. It is close to the hilum. There are large vessels here, so an 8 centimeter catheter can do some damage. But thankfully, in this case, that's not what happened. So I actually took care of this patient. I took the catheter out, and he did fine. Again, just to reiterate, though, the only indication for field decompression is tension pneumothorax. Safe position, fourth or fifth intercostal space is just anterior to the mid-axillary line, posterior to the anterior axillary line. So you got a couple inch space there where you're safe. Again, here's the border, and I'll show again, anywhere between this mid-axillary line and this red. So somewhere in here, and ideally it's right about there. That's where I would stick them if I were doing this. This is where I put trocars in the OR once my lungs dropped, and in general, I don't hit anything in that area, and that's a much longer device. But when the lung's down, this is a safe approach. Is the spot right here. All right, second case. This patient fell from a ladder. On scene, patient was unresponsive, heart rate was 120, pressure was down, he was hypoxic. The EMTs were ventilating the patient to BVM by MPA. There were other physical exam findings. There was no jugular venous distension. The trachea was midline. There was no paradoxical chest wall motion. So the question here was, did this patient warrant a decompression? Because there wasn't frank tension pneumo, right? Certainly was hypoxic, certainly respiratory failure, but was normotensive. And was tachycardic, but there's lots of reasons for someone who fell 25 to 30 feet off a ladder to be tachycardic. Again, midline mediastinum, no paradoxical chest wall motion, no hyperresonance, and no JVD. So this is sort of like to guide your thought process in the field. If you not seeing those things, maybe the problem isn't attention, and maybe they don't warrant a decompression. I think it's important to always be thinking about it, but that's but again, like we can do injury if we're doing the wrong thing for the wrong purpose. So here, as you can see, this lung was fully inflated on the scan. Again, we have the benefit of the CT scan. We have the tube of truth. It's a completely unfair advantage. And we recognize that. And we also recognize that when people make the decision in the field to do this, you are doing what you feel is the right thing for that patient at that time. And no one can really question that because you are the ones that are trained to do that. But it's our job to try to help improve that. So again, this one was through the seventh intercostal space. Again, it did clip the pleural space. You can see it enters the pleural space, but then it comes across and it ends up glancing into the liver there. So this patient also took it out of the liver and did okay. But again, the concern there is that it was placed for a patient that didn't have tension and it caused an injury. But I think a lot of this has to do with patient positioning and in finding the external landmarks for placing the catheter. So this was a patient who was found down after struck and run over by a vehicle. They sustained blunt thoracoabdominal trauma. Patient developed decreased breath sounds on the left, and a needle decompression device was placed in the field with pulsatile blood flow returned. The catheter was capped. That was absolutely the right move there. Patient was intubated on arrival at Maine Medical Center. The CT demonstrated decompression catheter was in the heart. Patient went emergently to the OR, had median sternotomy, cardiac injury repair, and bilateral chest tube placement. So this is the scan here of that patient. This is the decompression device. You can see it here entering into the left ventricle. And this is 8.4 centimeters. So this is how long that catheter is. The reason I measured this and took the picture was to show you just how long these things are. And so again, that if you're not getting air back on that syringe, then maybe the tension isn't the problem. And that's there's a little bit more nuance to applying these devices because there can be serious consequences if they're applied in the wrong way. You can also see in this that the lung is completely up, so tension pneumo wasn't the issue. So the placement was anterior to the axillary line, inferior to the nipple line, but the response was appropriate in the field. It was capped. They notified us immediately. We had an OR ready to go, and it was taken care of. Patient was stabilized and did okay postoperatively. But you can see this position here is not where we're looking for it. Yeah, like this is the costal margin here. This is the abdomen, but we're basically in line with the nipple anteriorly, not laterally. So it's a difference. You want to be in line with the nipple over here. This is the pectoralis major border. So that's the anterior border of the axilla. Here's the lat here. That's the posterior border of the axilla. So this catheter should be somewhere in this neighborhood when it's placed. So I overlaid terrible drawing skills on a computer, but I overlaid basically what I'm talking about here. So this is the nipple line as it carries along laterally to the back of the chest. This is the anterior border of the pectoralis major. This is the border of the latissimus posteriorly. Here is the mid-axillary line. So where you're looking to put this catheter is right about there. Okay. And you'll be safe in that general area. So and then again, too, when you're placing this, that arm should be up because that will move the soft tissue to the correct position. With the arm down, the soft tissue is actually lower than, and you will enter the chest at a lower position. But again, this is a critically injured patient where I think the team was trying to take life-threatening things off the table. And there can be no fault for that because this patient made it to the hospital alive and survived the injuries. Everything was treatable, everything could be dealt with. Okay. And if a complication happens and you notify us, that's perfect, right? I mean, like no one's perfect. I have complications too in the OR. I'd like to think I'm perfect, but everyone would, but that's not the case. I think every surgeon will tell you that it's a very humbling thing to do life-saving procedures on people. I guess the point I'm trying to make is that this isn't like punitive in any way. It's just to show the anatomy and show what can happen if if we're not approaching the anatomy in the right way. And I think if anything, the training deficit is on us. This is something that we need to train. And so that's why I'm talking today. These are my references. I'd love to hear some questions from folks, and see what you're thinking.
Folks, if you have any questions, please shoot them in the Q&A or the chat. I'm just going to scan here real quick. So we had one that was about where was the misplaced needle placed on that diagram?
Which one?
That's a good question. It was about 6 minutes ago.
Okay, so I'll go over all three. So on this diagram, the misplaced needle is here. Oh, I see. So again, if you were to see this here on the diagram, that needle is down here somewhere, right? And for the cardiac injury, that needle was over here. And so the two that were low here, probably because the arm may not have been raised when they were placed. And then this one, I think, was potentially a misunderstanding about what being in the nipple line means. It's not this line here, it's this line here. So you want to be in this position when you're placing that catheter. But yeah, I would say complication 1 was here, complication 2 was here, and then complication 3 was over here. So this is 1. And then this is 2. Oh, no, I'm sorry, that's 3. That's the heart. So 1 is here. So it's a little bit lower. So probably more anterior. So probably too far forward and too low here, because this is the 7th intercostal space. And then this one is the let's see, 1, 2, 3, 4, 5, 6, 7th intercostal space. The needle is there and there. So that's too low and too far forward, as we could see from the picture. And then this one, again, was too low and too anterior. Any other questions?
So we have, from the meta-analyses, do we know how frequently people are placing these needles incorrectly?
I think honestly, it's far less than correctly, I would say. And I think what we need to do is we need to look at the Maine state data with Matt because this protocol changed, I think, in 21. So we've got 4 years of analysis we could look at to see, the incidence, at least the incidence that's coming to Maine Medical Center. But I would say most often it is, it's always a very sick patient that these things happen to, someone who's really been hurt badly. You can tell all the mechanisms were severe. There was a guy fell 30 feet off a roof. One was flipped off his motorcycle, and I forget the other guy was in a, it was struck and run over by a vehicle, and it looked like the car ran over his chest. So there's these are always a situation where there's complications. Same thing in surgery too. Like our complications go up the sicker people are. So I think it'd be interesting to look at. It'd be interesting to look and see if the training makes a difference. Hopefully it does. Ideally, we're in November we can do skills stations with this, and in fact we're planning on doing that. And really just trying to move forward from here.
We did also have an example of the mid-clavicular line second intercostal. I think they're looking to see what would be if we had a picture of where that placement would be.
Oh, I don't have it in my slideshow, but I can show it on this patient here. So this is where the clavicles articulate with the sternum here. So the second intercostal space is the angle of Louis. That's where the manubrium meets the sternum. So this guy was pretty skinny, so it's easy to see. There's a rib there, right? So that's where the second rib articulates. If you look on anatomy, I'm sorry, I can put that into the slideshow next time I give it. But if you look at anatomy, Google it on your phone, angle of Louis, you can see the second rib articulates right here. So you would push down, follow that out, and stick right under here in the mid-clavicular line, right? So somewhere, from here to here, this, as I would say, this is mid-clavicular line. Whoops, sorry. And it comes, and so I would say that should be right about here where you're sticking that needle. And again, like when we do this, like for somebody that needs drainage in the ICU, or somebody that has an acute decompensation on the thoracic surgery floor or something like that. We used to do this a lot in residency. Have to do it when we do this approach. It's always with it's always with aspirating some fluid. That was a really good trick I learned as a second year resident. As soon as you see those bubbles, you're in. You can, in general, advance the catheter at that point.
Our next question is, could you please reiterate, summarize the differences in the diagnoses of pneumo versus hemothorax?
Sure. Yeah, we can go back over that real quick. Oops, trying not to change my slide. There was this I think is a really helpful table. Again, it sort of summarizes the differences. So attention pneumo, there's decreased or absent breath sounds. They are also decreased in massive hemothorax, but the rest of the exam is different. So the tension will be hyperresident if you were to tap on it, whereas a massive hemo will be dull. In attention pneumo, the airway will deviate away from the injured side. In a hemothorax, it should be midline. Neck veins will be distended in attention pneumo because the blood can't return to the heart centrally, because there's so much pressure that it's overwhelmed. It overwhelms the ability for the blood to return through the venous system. And in a massive hemothorax, they're in hemorrhagic shock. So they've lost 150 or 1,500 cc's of blood, which is more than a third of blood volume for most people, or about a third. So the neck veins will be collapsed if you're looking for that difference. And then again, the chest is usually mobile in a hemothorax if that's all they have. And then in a tension pneumothorax, there's probably some asymmetry. So when you're looking at the chest, the tension side doesn't move in or out. It's hyper expanded, and it's mobile. Whereas with a simple pneumothorax or a hemothorax, that side will move with respiration. That's actually a great telltale way to see it. If you're looking at the patient directly, the uninjured side is going to move normally. The injured side will not. Harder to see on patients with higher BMI. But if you have somebody but even then you may be able to see a difference. That's a good difference to look for. I think tracheal deviation, you may or may not see it. That can, especially again in higher BMI patients, it's more difficult to see where the trachea actually is. Same thing with neck veins. But I think the respiratory failure will be more pronounced in attention pneumo than in hemo. Hemo, they'll be tachypnic, but their chest will be moving. Typically, will be moving more symmetrically because they don't have the same internal pressure issue. With tension pneumo, the issue is there's so much pressure in the chest, the chest wall can't even move against it. Whereas with a hemothorax, the chest wall can move against that.
That looks like all the questions for now.
Okay. Well, thank you all again, and we appreciate what you do.
Wait, I did find one. I'm sorry. In the event your patient has multiple obvious chest deformities in the presence of all indications of pneumo, do you place the needle where it should be had a patient had no palpable landmarks due to the massive blunt trauma of the impact?
So you're saying the chest is so smashed you can't tell where the landmarks are?
Yes.
Or the answer would be yes. If it's completely caved in on the side, then a second intercostal space tube compression catheter might be better. If it's completely smashed in general, and this is another kind of takeaway for here, if you have a tension pneumo and you don't have a sucking chest wound, even though the chest is smashed, it should still be expanded. It's hard to create that much pressure in a completely collapsed chest wall. If they cave in, they're more likely to have a hemothorax. But that's case by case. I would say based on injury, you're still safe in that position. If it's completely collapsed to the side, then I would say go to the second intercostal space in the midclavicular line on the anterior chest.
Thank you. All right. Well, Dr. Shurtleff, thank you very much for your time today. If
Thank
anyone
you
has
all.
any questions, feel free to reach out to us. And I hope you all have a good day.
And all those folks that emailed me from last Zoom, I'm going to get back to you here as soon as I can here in the next day or two. Okay. And again, appreciate everything you guys do. And really glad to be working with you.
Have a great day, all.
Thanks.